Hello, I'm Larry Bennett, Program Chair for University of Cincinnati's Fire Science and Emergency Management Program. And on March 20th, 2019, we're going to have a seminar that's going to be free and open to the public. And it's going to be about leading the change with respect to care for those who are suffering from drug addiction, leading the change with respect to frequent callers for hospitals. And so I'm very honored to have three guests here today. And first, Judge Heather Russell from the Change Court, part of the Hamilton County Court of Municipal Court. All right, and to her right is Assistant Chief Will Mueller from Colerain Township, and to her left is Fire Chief John Centers from the City of Monroe Fire Department. So the focus on our seminar is change, and I'll start with you, Your Honor. Can you give us some sense of what the Change Court is about and what changes you're making in the lives of those in front of you?
Yeah, I'm happy to. I'm very honored to. So Change Court, actually, there is words behind that. Changing habits and setting new goals is empowering. So that's what we try and do in Change Court. It is, the inception came from two Cincinnati police officers who came to me in 2014 and asked me if I could provide some program for the prostitutes on West McMicken, who at the time were all heroin addicts. Wow. And through my years in the court, I realized they were asking for a specialty docket, and we created it. I, like anyone else with a heart, was reading all the headlines in the paper about our heroin problems and the spikes that would come up, and I wish I could be part of the solution, but I couldn't see how. As a municipal court, I have even fewer resources than common pleas courts. So I really had never really thought that as a municipal court judge I could do anything to bite off a piece of that problem and work on it, and I realized I could. And so now, almost 5 years later, I'm working in a program that was created with the help of lots of partners in Hamilton County, including CAT, to help prostitutes who are all in addiction. They are not all heroin addicts now. We have some alcoholics, we have some cocaine addicts, but they are all people who are really the neediest people I've ever encountered in over 30 years in the criminal justice system. And so it's a 2-year intensive supervision probation for people who have any kind of pending charge and have some aspect of prostitution in their background, whether it's a charge or whether we come to find out that the shoplifting was really as a result of not bringing home enough money that night to the pimp, and so they had to go out to shoplift for dinner. So it's interesting to go underneath the layers of a crime and see what prompted it. So I've changed in that I realize when I have a person in front of me who has a needle charge or a shoplifting charge that I would always see as a criminal, I really now can look at them and see them as a victim. Could be a victim of their own bad choices, but definitely a victim because they're now in addiction and they are involved in criminal behavior to maintain their addiction. Wow. So it's a huge change to see people coming in front of me as victims, and to realize, as I think our whole country is, that incarceration is not the answer for addiction. It's very intensive supervision and very intensive human connection, because the people I'm dealing with are missing that. Wow. And so that's what we offer. I see them every week, every Wednesday afternoon, and we help them feel their feelings. There's no way around it. You have to go through it. And at the end, the goal is always that they're going to have their own housing, that they've reconnected to their family if they want to, but really they're gaining their own self back, that they are gaining the confidence that they had none of when I met them, when they were arrested out on the street. So
amazing. Wow. Thank you so much. Thanks for sharing. Will, change. Every time I pick up the trade industry, I'm hearing about Colerain Township and quick response teams and now safe stations. What kind of changes have happened at your department since you launched all this?
We've gone We've undergone quite a bit of change, actually, in the last 3 years. The biggest piece of that has been the culture within our organization and within our community. We look at culture, where it needs to change is across this addiction spectrum. We realize that culture needs to change within our communities, within our organizations, public safety organizations, within our administrative and political organizations, and also within the addiction community. However, from a public safety standpoint, culture change has been driven mostly by the programs themselves, allowing people to behave differently. So culture change in our organization has been driven by allowing people to act in a certain way that changes their perception, which then changes the way they think, which is the John Shook principle, who was widely responsible for Toyota's European expansion. And in his organization at the time, he allowed culture to change within his organizations by driving behavior changes, which then drove the way they perceived things, saw things, which then finally changed the way they think. When we think about culture change, we usually look at changing the way people think, allowing them to change the way they see something, and then changing the behavior. But by taking the reverse approach, we've been very successful in achieving buy-in from organizations within these programs that are creating opportunities for our personnel to step outside of their traditional roles.
Wow. So if someone is saved today with Narcan, what's the next process in a quick response team?
Within 3 to 5 days, the quick response team will follow up with the individual that's overdosed, connecting them to treatment and removing in the process several barriers that would traditionally stop them from treatment. So we remove the stigma barrier, we remove the time barrier, we remove the transportation barrier. These things all stood in the way previously. The quick response team's responsible for taking away those barriers and getting people connected as quickly as possible.
Wow, what kind of data collection have you done?
So as of December 31st, 2017, our program, which began in July of 2015, has conducted 390 follow-ups. Of the 390 follow-ups, right around 80% have been connected to recovery resources. What that's done for our organization in terms of overdose responses in our community, we've seen a reduction in 62%, or of 62% from in Colerain Township as a result of this, which is, I'm going to have to rephrase that because that was bad.
It's all right.
The numbers get me boggled up sometimes. Okay, so as a result of the quick response team's efforts and now the Safe Station effort, we've seen a 62% reduction in overdose responses in 2018 from the same time period in 2017.
Wow, unbelievable. Wow. John, frequent flyers. We've all in our fire and EMS world have repeatedly transported, again and again and again, phone calls again and again and again, and frankly had very little relationships with our local hospitals. We would take them there, but never have an otherwise partnership. You all have launched a partnership. Can you tell us about that change?
Yes, we have. So we started our program on a trial basis in late 2015, early 2016. And our goal was to be able to establish parameters to initiate a program to help our elderly community, our community dwelling seniors, and determine where they were having problems with the healthcare system. We interviewed approximately 70 of our residents, and we determined that the largest, most significant gap in the system was the discharge process out of the hospital. These patients have been sick and admitted for 7, 10, 14 days. Many times they find out on the day that they're going to be discharged that it's their discharge day. And they have pretty substantial discharge instructions that go with that process. So changes in medications, physical capabilities, follow-up visits, visits with specialists, all these different things that are in this giant pile of paperwork. And they had a lot of trouble getting through that and remembering what they were told during discharge. What we're trying to do with our partnership program is to be able to be a part of that discharge process, to be present at the time of discharge with our patients that are discharged back to our city, or at least to follow up within a 24-hour period. Our trial right now is looking at community paramedicine combined with community telemedicine, utilizing a telemedicine product to collect data from the patients from a number of different areas, not only their physical capabilities at home, their emotional status at home if they happen to live by themselves, but also all the medical, clinical pieces that go with that. So all that information is gathered, it's sent to a secure cloud-based server, and it's administered directly to the physician real time, so they can look at how their patient's doing at home through data graphs with peaks and valleys and different things that will help them to determine if they need to be back in the system or not be in the system.
Amazing. Wow. Judge, observe urine screens.
Yes.
Can you tell us how that works in your program?
Yes. When I was building this program for Change Court, I wanted to be able to hold myself out as a specialty docket, which is within judicial realm, is to get a certification by the Ohio Supreme Court. There are about 85 standards that you have to show them that you are complying with in order to carry that title as a certified docket. And the very last point for me that needed fixing before I could claim that title of certified specialty docket was the urine screen. So the Ohio Supreme Court requires drug courts, which Change Court is a drug court plus trauma court, to show that all the collaborative partners I'm using are doing random urines at least twice weekly, and they are random and observed. So literally, an observer must see the liquid coming from the body, which actually some people have some problems with that privacy issues. But in order to be in my program, I have to be able to show that, and every week my case managers have to show me that it's being done and that we're in compliance. Otherwise, I will lose my certification. So the theory behind that is that all the participants in Change Court or any other specialty court will have an expectation that at any time, any day, they could be randomly directed to drop a urine. So it helps to keep them clean and sober.
Wow.
Because the way we were doing it previously, there were ways that you could sneak in. Some drugs metabolize faster than others, so perhaps you could go on a drinking binge and then know that you're not going to be tested again, and you would be able to flush the alcohol out. Other drugs we know take longer. For instance, marijuana, they wouldn't be able to use marijuana and get by under the old standards, but under the new standards, you could be tested every day. So, and they know that, the participants.
Wow. So, Will, with respect to your quick response team, who's on the team? What skill set, and how do you get your residents into these treatment facilities?
So the team is comprised of 3 individuals. The first one is a law enforcement officer that provides safety and supply reduction and investigation to the team. The second member is a firefighter paramedic who brings the medical screening piece to it, which is a significant barrier to treatment. A lot of times these individuals are not well. They present with comorbid conditions which require intervention prior to treatment. So we try to eliminate that barrier up front. The third person is, of course, the addiction specialist and counselor. And how they get connected to treatment is through Addiction Services Council of Cincinnati. Not only are they a treatment agency, but they're also a referral agency, and know agencies in and out around our region and know the capabilities of each. As they assess each individual and their individual needs, they can place them appropriately.
Wow, it's amazing. And John, with respect to your hospital partnership, how does the hospital go about communicating to you that they have a patient who lives in your city?
So we have about a 24-member team between the fire department and the hospital right now, the bulk of those being hospital employees. And they're discharge services folks and some of their other data-driven folks within the hospital have our community paramedics cell and email and fax and all the other information they need
Sure.
from them. So when they have a patient that meets the criteria, which is usually some sort of an exacerbated medical condition, or multiple medical conditions that typically result in multiple transports. They will text or email or call him direct and say, we have a patient that's being discharged. We've had her in the facility 3, 4, 5 times this year, and she's been readmitted 2 out of those 3 or 4 or 5 times. So she's on the high end of risk for reinsertion into their system. And then he will either go to the hospital, meet with them directly during the discharge process, or our benchmark is to be able to have him at their home within 24 hours after discharge.
Wow, wow. From a personal point of view, what impact has this had on the medics who are in the program?
Well, as everything else, it started off kind of slow, but I think as people see not only the reduction in transports, but that we're building a better home life for these people by making sure that they don't end up back in the healthcare system, that they don't end up ill again. What we're seeing now is that most of our referrals are coming from our paramedics in the field. So we do 3,300 calls or so a year, but we're getting more and more referrals back to our community paramedic from our field paramedics because they want to make sure people get in the program and that they get taken care of.
Got it. Makes sense. And Will, same thing with you. From a personal perspective, what's the impact on the medics who have been serving on these quick response teams?
Well, I think we hear words like compassion fatigue, and we respond to those accordingly. However, the overdoses, while significant in number and significant in death toll, only represent 2.2% of our overall run volume.
Wow.
If we want to talk compassion fatigue, then we need to talk about compassion fatigue holistically in a way that it really addresses the issue. So then we need to bring in the falls component. Our agency responds to over 1,000 falls per year, which is 13% of our run volume. So when we look at compassion fatigue, let's look at how it's affected by the falls, the EMS lift assist, assisting people back to bed, and talk about it holistically instead of pointing toward one demographic of individuals and saying that you are the issue.
Wow, amazing. And Your Honor, you're a former prosecutor,
Yeah.
as am I. What's the impact on you personally, given that background as a prosecutor, and now you're getting to know these clients,
Yeah.
defendants on a more personal basis?
It is very different. So I call it equipause. 17 years as a prosecutor and 17 years as a judge now. So there is a word. Where I was only able to see criminal defendants as criminals, personally to see sort of the sociology behind how this particular population has become criminalized, and to see them as victims is a huge change for me, and it actually bleeds over into my regular docket because, in addition to doing this work every Wednesday afternoon, I'm a regular municipal court judge with a regular caseload every morning, and so I see it now, especially in municipal court where there are good people making bad decisions as opposed to maybe some of the more serious crimes and common pleas where I used to prosecute. That there's not a whole lot you can do in the more serious crimes other than seek justice for a victim. But in municipal court, I was always aware that looking at a defendant, these defendants are people that could change their behavior and could lead productive lives. Maybe they made one bad decision with an OVI.
Right.
Maybe they've made a series of bad decisions with shoplifting, but they can be rehabilitated. But to realize now that almost everyone coming in front of me, like whatever happened in your life to bring you to this point where you're standing in front of a judge, it does give me a different insight and a different approach into dealing with every case, not just the addicts who come in front of me.
Well, thank you all very much. We're physically here at the CAT House, the Center for Addiction Treatment, Ezra Charles Drive, off of I-75. And this is where we will be on March 20th. Again, free seminar, open to the public, 9 a.m. till noon. And thank you very much for sharing about the changes in your lives. Thank you.
My pleasure. Thank you.